Welcome to today's Savant live webinar. We're glad to have today with us Margo Steinlage of Steinlage Insurance. I'm Joel Cundick, financial advisor for Savant out of our McLean, Virginia office. Just a brief bit about Savant. We have offices in 32 locations in multiple states. We started in 1986 and we've grown to now over 140 advisors. We pride ourselves at Savant at helping with times of transition. And one of the major times of transition is retirement. And oftentimes around retirement, that's when Medicare kicks in. So we're glad to be able to be putting this on today. Our goal overall is to help our clients build an ideal future. And we're really thrilled to have Margo with us today. Welcome, Margo. Thank you for being with us today.
Thank you, Joel. Let me go ahead and share my screen here. Give me 1 second.
Sure. And while you do that, I think one of the things I've noticed with my clients as we go through the arc of a career in retirement, we work under one health system generally most of our careers, and then we have to learn a new set of rules as retirement approaches. Medicare is something actually a lot of my clients look forward to. They like the idea of what a lower cost health plan might be, but there's a lot of uncertainty around, well, what are the details of this insurance? And it is unique. It's a different form of coverage than what we've all been dealing with in our working years. So I'll turn the time over to you, Margo.
Awesome. Thank you, Joel. And right out of the gate, we got a great question that just highlights what you mentioned about uniqueness. And every state is very different with their little nuances around Medicare, specifically with the supplements. So one of the things we pride ourselves here at Steinlage Insurance is really offering thorough information, regardless of where you reside. If you're in New York, California, Florida, we want to give you kind of the full playing field of product available and all of those little nuances, regardless of where you reside or want to reside when you do retire. So all of the services that we provide here at Steinlage are free to you. We are independent brokers. Again, we pride ourselves on our contracts and appointments with all of the national carriers, whether it's a Medicare supplement, also known as Medigap, Medicare Advantage, all of the Part D carriers. Usually states have about 30 different drug plan options. In your specific zip code, we can go in there and work with any of those carriers. A lot of what we do also is if you are retiring and you are the older spouse, you need Medicare, you may have a younger spouse who needs COBRA or an ACA. We come in and offer this holistic approach to health insurance consulting and really look at your entire family dynamic, not just your specific Medicare needs, but also we can assist with that ACA transition or COBRA transition for the younger spouse. Or maybe you have children on your group health plan and, what's their next move regarding health insurance. Also, we are a third generation business. So my dad has always, and my grandfather always harked on just a customer service approach. So one of the things we do here at Steinlage for all of our current clients is this proactive annual review. So as you move into Medicare, we're kind of turning back all the regulation and layers of Medicare and helping you get the best plan based on your goals, your long-term goals, your current medications, your doctors. And we review that every year. So we're kicking off our review for current clients as early as of July this year. All of our clients will receive our review form, and that just lets us take a peek if there's any nuances with a plan change, a formulary change. Your drug copay goes from $45 to $110. We want you to know, be aware of this change and potentially save you quite a bit of money with making recommendations. So also we are working with a lot of high income individuals, and some of you may be able to appeal this IRMA income surcharge if you are deemed a high earning individual once you transition to Medicare. I'm going to cover the IRMA in detail towards the end of this webinar, so I want to get to work here. We are nationwide. But the focus of this webinar will be three kind of moving parts. First, who is eligible for Medicare? What are the rules around working after 65? And then the second component will be really pulling back the layers of Medicare Supplement, Medicare Advantage, Part D. What are those different moving plan options within Medicare, and how do they work with Medicare, original Medicare? What are the pros and cons? And then lastly, we will touch base on income adjustments for the high earning individuals. The donut hole in Biden's recent passing in August of 2022 of the Inflation Reduction Act and how that is changing your Part D exposure once you do move to Medicare. And then we'll open it up for Q&A based on Joel's timeline here. So the general rule here for Medicare eligibility is that anyone turning 65 needs to sign up for Part A and Part B. Again, that's the general rule. You need to sign up for Part A and Part B in your 7-month window to avoid any gaps in your coverage or long-term, lifelong penalties from Medicare. So 3 months before your birth month, and 3 months after gives you a 7-month window to sign up for Medicare when you turn 65. The exception to that rule, which many of you will fall into, is if you or your spouse plan to work after 65. If the employer that is offering you the group coverage is a large employer, then that large employer can maintain a primary payer status. So what that means is Medicare becomes optional if you are working or your spouse is working for a large employer, and that large employer is offering you group health coverage. If that's the case, then Medicare is optional. You can delay both Part A and Part B, or you can pick up the free Part A hospital benefit and delay the premium benefit, Part B, especially if you're a high earner, you can delay that Part B benefit until further date. When you retire, you stop working, you get fired, whatever that scenario is, you can delay the Part B component without any penalties. When you're ready to retire, or if you lose access to that large group plan through your employer or your spouse's employer, that will trigger a special election window to pick up Part A or Part B, plus your supplement, plus your drug plan or advantage plan, whichever path you want to take. You'll trigger a special election window that will get you into Medicare without any penalties or gaps in your coverage. If you have a large employer, which means 20 or more full or part-time employees, then Medicare is optional. And one of the hiccups to watch out for here is if you are the primary policy holder on your HSA and you're maxing out that HSA and you plan to continue working with your large employer for the foreseeable future, then under most circumstances, you'll want to delay both Part A and Part B. IRS does not allow you to max out your HSA contribution or contribute into your HSA and pick up or enroll in the Part A hospital free benefit under Medicare. You're kind of double dipping. You have a high deductible HSA benefit and you're maxing it out, getting the tax benefit, and you have a low deductible Part A benefit. So in the eyes of IRS, you cannot do that. If you delay Medicare at 65, both Part A and Part B, and stay on this large group plan and max out your HSA, when you're nearing retirement and you call me and you say, hey, Margo, I need you to help me sign up for Medicare and transition into Medicare. When we start your Medicare paperwork and we're submitting it to Social Security, you'll have a 6-month retroactive look back on your Medicare Part A start date. This is important because we need to time your HSA contributions with that 6-month look back to avoid any risk of an audit or over contributions into your HSA. If you are under 20, if you are working for an employer with fewer than 20 employees, then under most circumstances, Medicare Part A and Part B is required to be the primary payer. Then the next level of analysis that our team will do is what makes sense to keep your Medicare as primary and your small group plan as secondary, or maybe going supplement and drug is a better deal because it's better coverage, cheaper premium, more access to nationwide providers, or maybe you have a younger spouse and kids on your group plan and you need to keep that secondary group plan as your at play to keep your spouse and your children on the plan. So again, a lot of what we do is just consult. And then if you're ready to move to Medicare, and then even after that, if you're ready to come off your group plan as a secondary and into the supplement world, then we start looking at carrier specific products. Again, we're working with all of the nationwide carriers, your Blues, your Blue Crosses, United Healthcare, AARP is a big name out there, Aetna, Cigna, Humana, Mutual. There's plenty of carriers out there. I could care less which route you go. What we want to do is match you with the best product when you're ready to move into Medicare, which for many of you is not at 65. If you're working with this large employer, 20 or more employees, then we are actually under most circumstances delaying it unless your large employer coverage is not that competitive. Again, it's going to boil down to income, premiums on your group plan, premiums on your IRMA, if you're a high earner on Medicare. Again, we're pulling back all of those layers here. If you are turning 65 and maybe you retired before you turned 65 and you're on COBRA, COBRA is not active group coverage. Anytime, excuse me, anytime COBRA comes into the equation, and you're 65 or older, you need to sign up for Medicare as soon as possible to avoid total gap in your coverage and penalties here. I'm going to skip this for timing, but generally you can use those HSA funds for anything medically qualified, except for your Medicare supplement premiums once you're enrolled in a supplement plan. Okay, next part of the equation here is what is Medicare? I know I'm throwing a lot out here at you. Hopefully some of you have a little bit of background in Medicare. If not, this will be new to you. So when you are turning 65 and you fall into the bucket of, I have to sign up for Medicare at 65. I retired early. I have ACA individual coverage. I have a small group employer plan. I have to sign up for Medicare Part A and Part B. You'll get a red, white, and blue card as soon as you sign up for Medicare. Or maybe you delayed Medicare and you're watching this and you say, you know, hey, Joel, I want to retire January 1st. I need to sign up for Part A or Part B for January 1st. When you do that, you're going to get a red, white, and blue card that says Part A and Part B. Part A for most of us is going to be zero premium because we paid federal taxes and we funded the Part A benefit. Some of you may have never worked in your life and your spouse was the one working. You can tap into your spouse's work history and combine or use all of that working spouse's history to reap this Part A benefit. It's 10 years of work history or 40 quarters to get the zero premium Part A benefit. Part B medical will have a standard Part B premium, and that adjusts every year and is set by Medicare. This year, the standard rate is $164.90 per month. If you are low income or high income, then the standard Part B premium will adjust based on your income. And that's called IRMA, income related monthly adjusted amount. And I'll show you a graph with all of the IRMA levels that you could fall into based on your modified AGI. So you get your red, white, and blue card. We're now transitioning you into Medicare, and we have yet to look at the ancillary products, the supplement, the drug, and the advantage. Or maybe you have a retiree option at play that we can also compare. Once you get your red, white, and blue card, if you go into the hospital with just your Medicare card, you'll have a $1,600 per 60-day occurrence deductible walking into the hospital as an inpatient. That resets every 60-day occurrence. If you walk in for outpatient surgery or an MRI, or you need, physical therapy, that will trigger your annual Part B deductible, which is currently $226 per year. Once you satisfy that deductible, then Medicare will cover 80% of the bill. Your exposure here is 20% coinsurance. So there's no cap here on your 20% risk. You'll also see with your red, white, and blue card, there's no built-in prescription coverage with just your red, white, and blue card. There's no dental, there's no vision, there's no hearing. This is where all of the ancillary products come into play to fill these gaps of original Medicare. Your Part A, $1,600 60-day occurrence deductible. Your Part B deductible, $226, very nominal. And the 20% gap in Medicare, plus prescription coverage, plus dental and vision. There's a lot of add-ons here that you can get. How do we fill these gaps in Medicare? So our team has already enrolled you in Medicare, or you've enrolled, you self-enrolled. Now, the next part of the equation is finding the right coverage based on your needs. Again, some of you may have a third option here, a retiree plan that we can compare to the private market. So here you have essentially two options. Some of you may have that third retiree option. Option one is you can go with original Medicare, your red, white, and blue card, and then you'll add a Medicare supplement plan or a Medigap plan as your secondary payer. In addition to that, you'll need to add a standalone Part D drug plan. If you want dental and vision, this would also be a separate addition to this level of coverage. This is the left side of your screen, option one. The alternative is for you to go option two. You enroll in a zero premium or low premium HMO, PPO, Medicare Advantage plan. Those are called Part C plans. Part C combines original Medicare, Part A, Part B, Part D, and you have this managed care HMO, PPO plan that is ultimately running the show. No matter which direction you choose, option one, option two, or you have option three, a retiree plan. No matter which option you choose, this Part B standard premium, the $164.90 that you're paying to Medicare, or some of you may be seeing that draft out of your Social Security benefit, depending on your age and if you're collecting. That $164.90 premium to Medicare for Part B is standard regardless of your decision making here. IRMA is also tacked on there if you're high income and we can't appeal it regardless of your decision. So let's dive into kind of the pros and cons. Again, I'm on a high level here, and I know there's a lot of you all over the country here. So there may be little tweaks to your state specific rules, but again, 98% of states follow this setup. Okay. Let's say you want the Cadillac coverage or the best level of coverage that you can get once you move to Medicare. This is your Medicare as your primary payer, your red, white, and blue card, and you add a Medicare supplement, also known as Medigap plan. This level of coverage will allow you to go nationwide to any doctor that takes Medicare. If you want to go to Mayo Clinic, if you want to go to Johns Hopkins. You show your Medicare card, you ask providers, do you accept original Medicare? If they do, then Medicare will be the primary payer. And then regardless of your supplement carrier, they are mandated to pay once Medicare is triggered. So there's no asking, do you take my HMO, my PPO, my United Healthcare plan, my Aetna plan? No, you'll always ask, do you take original Medicare? Within the supplement market, you generally have Plan F, Plan G, Plan N. Some of you may have already enrolled in Medicare and you're just watching this video for a recap. If you turn 65 prior to January 1st of 2020, then you were eligible for a Plan F, as in Frank supplement. Anyone new to Medicare after 2020 cannot get the Plan F. Plan F supplements with original Medicare cover 100% of your medical and hospital and Medicare approved charges. You show your Medicare card, you show your supplement F card, and you have 100% nationwide medical and hospital coverage with any Medicare provider and for any Medicare approved charge. Plan F picks up that $1,600 deductible, the $226 Part B deductible, and the 20% coinsurance. For those of you turning 65 after 2020, which is probably most of you on here, the next best Cadillac option at play here is a Plan G as in girl. You show your Medicare card as the primary, you show your supplement G card as the secondary. That level of coverage gives you 100% for medical and hospital, except for the Part B standard deductible, which is $226. So you walk in for heart surgery, you're in the hospital for a week, you need PT for 6 weeks, and then you have follow-up visits. Your only out-of-pocket there is $226 for the year. Plan N is one step down. Plan N, you show your Medicare card, you show your supplement N card, you pay the $226 per year deductible, $20 copays for provider visits, $50 ER copay, and then the biggest kind of exposure here with a Plan N is called Part B access charges. And if you go to a doctor that accepts Medicare, that doctor has the choice to agree to Medicare's reimbursement charges, which means they agree to bill Medicare the Medicare approved rates. If you go to a doctor that opts into Medicare but does not accept assignment, they do not agree to Medicare's reimbursement rates, then that doctor can charge you as the patient 15% above Medicare's reimbursement rate. You're responsible for that excess 15% charge with a Plan N. With a supplement G or a supplement N, or excuse me, supplement G and supplement F, those two supplements will pick up that Part B access charge. Most doctors take assignment, but again, that's where we'll go in and we'll ask for your list of doctors, which is a little, it's part of our intake form. And we want to verify that, yes, your doctors take Medicare and they agree to Medicare assignment so that you're not exposed or walking into a visit and you get hit with a excess charge. Or, hey, I can maintain all of my doctors because they take Medicare. If you're going with this level of coverage, regardless of the supplement you choose, you'll need to sign up for a Part D drug plan. Even if you're not on any medications, Medicare says that Part D is optional, but they will trigger a late enrollment penalty if and when you add drug coverage down the road. And that penalty can really stack up. I mean, I get clients who are in their 70s or early 80s. Usually it's parents of those individuals that are kids of those individuals that call and say, hey, mom needs drug coverage. She's on a $1,000 medication. Well, she's never had drug coverage. She delayed it. she has a $75 or $120 penalty per month because she delayed Medicare. Always get a drug plan. The cheapest drug plans, if you're in Colorado, there's a $3 drug plan. Most range about $3 to $10 on the cheap end, all the way up to about $100 on the high end. What we look at with our drugs and our drug recommendations is total cost to you as the consumer, with premiums being paid, your deductible, and then the biggest research component is your actual copays under all of these drug plans. You know, a $100 drug plan may have a $30 copay on your medication. A $7 drug plan may have a $10 copay. Everybody has different negotiated rates and different formularies. So we really pull back the layers to make sure our drug recommendation is giving you the best deal on many factors, not just premium or copay. It's looking at the whole picture. And your pharmacy comes into play. What's your preferred pharmacy? Do you want to use CVS? Do you want to use Walgreens? Or do you want to use kind of a smaller local family-owned pharmacy? Again, if you want to add dental and vision, that would be a separate policy in addition to the drug coverage. The alternative here is to say, hey, Margo, you know, I love the Cadillac option. It looks great, but maybe I don't like the premiums that I'm paying. It's a lot of upfront cost. The alternative is a Medicare Advantage styled plan. These are what you see in the fall on TV marketing, like marketed to you every fall. Joe Namath was pushing a lot of the Medicare Advantage product. Joe Namath does not have a Medicare Advantage plan, I can tell you that. But we have many clients who do have Medicare Advantage. I would say nationwide, it's like half go Advantage, half go supplement. If you are looking for coverage, Medicare Advantage offers you a very low cost option. It's zero premium in most counties and most states. Zero premium for your Medicare Advantage plan. You still pay the Part B premium, the $164.90. You sign up for one of these zero premium HMO or PPO or whatever styled plans in your county, and that becomes your primary payer, that HMO or PPO or cost plus plan. It becomes your primary payer. It is now managing your care. Original Medicare is no longer the dictator managing your care. Your HMO or PPO plan becomes the primary dictator. It's zero premium on the front end. However, when you start utilizing care, that's when you pay for each service rendered. If you go in for surgery, you're paying the surgery fee, the doctor fee. You have copays for an ER visit, a per day hospital copay, or a MRI coinsurance of 20%. As you use care, those copays are adding up to meet your plan's max out of pocket. And this is where we see the real discrepancy on a national level. If you're in the Midwest or down in Florida, you can find, or California, you can find Advantage plans that have a max out of pocket at $1,200, $1,500 per year. On the East Coast, up north, you're looking at higher max out of pockets, less competitive product in some states. When you select a Medicare Advantage plan, again, it's low cost on the front end, but it can become pretty high cost on the back end if you're routinely hitting those max out of pockets every year. Another negative, again, I see it all in my business. Another negative here is that Medicare Advantage plans there's a lot of red tape, prior authorizations, restrictions at play that can become a headache for you. If you're in a skilled nursing facility, if you're wanting surgery, your doctor is recommending surgery, and the Advantage plan is coming in and saying, hey, we're not authorizing this, that can be a pinch point and make the supplement product a little bit more attractive to you. One of the negatives here is that when you are making this initial decision of, hey, I want to go Medicare supplement or I want to go Advantage, I'm healthy, I can afford the supplement, but I'm healthy right now. Why would I not go Medicare Advantage? Okay. In most states, again, some of you are going to reside in a very unique state that this does not, this rule does not fall under, or you do not fall under this general rule. But in most states, 45 of the 50 states, if you choose an Advantage plan when you first become eligible for Medicare, you're turning 65 or you're retiring after 65, and you later want to move 3, 4, 5 years later, you become unhealthy and you say, hey, Margo, I want to move from my Advantage plan over to a supplement plan. In most states, you have to answer medical health questions and underwriting to get approved by your Medicare supplement carrier. And most of the time, people are jumping ship from your Advantage plan over to a supplement because you're unhealthy, because you're hitting this red tape, this restriction, this prior authorization. It's a push-pull with your Advantage plan. You're sick of it. You want to move to a supplement. You have to pass underwriting. And if they deny you because you're too high of a health risk for them, then you're left in the Medicare Advantage market. Now, we can shop that Medicare Advantage market every year in the fall. We can go HMO to PPO, PPO to HMO, but you're still funneled with what the market is allowing you to enroll in. You know, what's the PPO market that year in your zip code? What's the HMO market look like? Did your Medicare Advantage plan drop 5% of their doctors, and one of your doctors was part of that 5%? I saw that happen in Missouri when I was living there, which was a little unfortunate. But so there's a lot to be aware of if you do find this Medicare Advantage path attractive, which some of you may, but my goal is to say, hey, here's the negatives that you need to be aware of, regardless of your decision. And if you choose one route and later want to move to the supplement, if you choose Advantage and later move to a supplement, know what those consequences are. If you choose supplement at the start of your Medicare enrollment and later want to move to an Advantage plan, that's always easy to do. The Advantage plans will always take you regardless of your pre-existing and your medical condition. If you choose a supplement at the start of your Medicare enrollment, in most states, if you want to move supplement to supplement, you want to rate shop, you know, Cigna, and you want to move to a Blue Cross plan, Cigna G to a Blue Cross supplement G. In most states, you have to go through medical underwriting to rate shop your supplement as well. So again, your initial decision here will have long-term consequences in most states. You know, off the top of my head, Connecticut, New York, Maine all have like rolling open enrollment periods. You can float from Advantage to supplement without health questions. There's a few others in there, but again, most states. I'm in Virginia. Our home office is in Missouri. I have clients that I'm working with this morning that are in Arizona. They have to answer health questions to go supplement to supplement. The drug plans are always easy to change. So if your drugs are changing, the market's shifting, there's cheaper, more competitive product coming on the market for the upcoming year. Every October 15th through December 7th, we can shop those drug plans. And this is where we have the most volatility in the Medicare market. Drug plans are changing every year. I would say 25% of my clients have to make a change, or they don't have to, they should, because their drug went from a tier 3 to a tier 4 on the formulary for next year. Their drug plan went from $20 to $60. Their pharmacy got dropped out of network. So just taking a peek at those drug plans is critical. If you're on Medicare right now, make sure you're reviewing the drug coverage. Okay, last part of the presentation here is, I know I'm on the clock here, so IRMA.
You're doing just fine, Margo, plenty of time.
I could talk about this all day, and I know I say this all the time, but I basically was born with a Medicare card, and my husband hates me because this is all I talk about 24/7. So, so many of you are high earners. And that Medicare deems you a high earner if you're a single tax filer making above $97,000 in modified AGI. And for most of you, the modified AGI is the same as your adjusted gross income. If you're a joint filing couple, 194,000 makes you a high earning individual. So when you're ready to move into Medicare, you're turning 65 and you have to sign up for Medicare, or you delayed Medicare because you were on large group coverage, you kept it as primary, and now you're retiring. When you move into Medicare and you sign up specifically for the Part B component, Medicare will have the standard $164.90 rate, plus they'll add this IRMA surcharge if you're prior to your tax return when you are enrolling in Medicare. So you enroll in Medicare in 2023, your prior 2021 tax return is dictating what you pay in 2023. What you filed in modified AGI in 2021 will dictate what you pay in Medicare and IRMA charges for 2023. Medicare is constantly updating their information with IRS. So in 2024, you're going to get a notification right around January, maybe a little bit before January, stating, here's what you owe in 2024 because we have your 2022 tax information. That is automatic. What Medicare doesn't know is if you've had a life event that alters your income trajectory. So in 2021, you were working, you made great money, and then maybe in 2022 or 2023, you retired and your income went from 500,000 to 200,000 in modified AGI, an anticipated modified AGI for the retirement year. We can fast track Medicare and we can say, hey, I've had this life event. I retired, COVID shifted my work. I reduced my work hours, or my spouse passed away. My income has drastically changed. Here's proof of that life event. Here's my retirement letter. Here's, my divorce decree. And here's my anticipated modified AGI for 2022, 2023, or 2024, depending on the year. And when we tell Medicare, hey, I've had this life event, they will assess and reduce your IRMA that's owed and use your anticipated retirement income or retirement modified AGI rather than your high earning year modified AGI. So I'm going back to the graph here. So if you can see here in the second column, filing joint tax return. If you're working, you're turning 65, when we're doing our initial kind of onboarding intake form, we're asking for your income information. I don't need to know if you made 40 million. What I need to know and what my team needs to know is if you fall into one of these IRMA brackets, we want to put that on your radar that, hey, Medicare isn't free. Medicare won't cost you $164. You're going to have this surcharge on the far right column of $200, $300, $400, $500 in addition to your Part B standard rate, the 164. If again, when you're turning 65 and you plan to work and we're doing this consultation and we see that you're a high earner, we're taking that IRMA adjustment into the equation when we're making your recommendation. And if you're paying, $200, $300 a month for your group coverage and it's a high deductible and you don't have any IRMA at play, Medicare probably is more attractive for you if it's just you on your group plan. But if it's you and maybe a spouse and some kids on the plan and IRMA is coming into play, that's where we're generally recommending, hey, you don't need us yet. Delay Medicare A or just Medicare A and B or just B, and talk to us in 2 years when you're ready to retire or if something shifts drastically within your life and it forces you into Medicare. But you can see here, Medicare can get pretty expensive for a husband and wife who are both moving into Medicare, who maintain a high income into retirement. or maybe are starting that required minimum distribution in their 70s, this IRMA may be triggered 2 years after that required minimum distribution. Or if you have a large one-off home sale, that will come back and bite you, not only in taxes paid, but in another consequence is your IRMA that you may have to pay 2 years later when Medicare catches up with the IRS. If we see that you can appeal through our conversation with you, that 1-hour consultation, then we're going to go ahead and prompt you and help you navigate the appeal and request for reduction and work with you to get that filed with Social Security. Okay, last part of the equation here is the donut hole. Some of you may have heard of this term, others it might be brand new. I like to go straight to my handy graph here. So right now, no matter what drug coverage you get, if you go Medicare with a supplement and a standalone drug plan, or maybe you go Medicare Advantage, HMO or PPO, you will have built-in drug coverage, whether you're getting a Part D plan or you're going the Advantage plan route. All of those drug plans have the same structure, and this is your structure here on the screen. Some of the plans may have a deductible, some may not. Once you meet your plan's deductible, then you go straight into this initial coverage phase where you're paying a copay on your medications. You know, if you're going to fill Eliquis, which is like $700 in retail cost, I'm going to round up to $1,000 in retail costs from simplicity here. If you go fill $1,000 Eliquis under Medicare, regardless of your plan, and you walk into CVS or Walgreens, your preferred pharmacy, you're going to pay a roughly $35 to $45 copay for Eliquis during this initial coverage phase. What Medicare is calculating on the back end is the retail cost of all of your medications being filled every month. So you go fill Eliquis, you go fill lisinopril, maybe you're on Ozempic and you're filling Ozempic. Medicare's calculating that total retail cost. And once the total cost meets $4,600 roughly, you now are taken out of this simple copay structure, paying $45 for Eliquis, $47 for Ozempic. And you're pushed into the donut hole where your cost structure shifts. Instead of paying that copay, you now go to a flat 25% coinsurance on all medications being filled throughout the year. So once you meet that $4,600 retail cost threshold, and the drug plan and Medicare are calculating that, now you go to the 25% coinsurance. 25% coinsurance on $1,000 retail cost drug is $250. This is the gap in Medicare right now, is the drug piece, the drug component. What Biden's Inflation Reduction Act is doing is shifting this cost exposure to you as the Medicare beneficiary in 2024 and 2025. So right now, under current regulation and structure, you pay the 25% coinsurance until your true out-of-pocket, what you've paid in deductible for the year, the copays you paid in that initial coverage phase, the 25% coinsurance that you've paid in this donut hole, and there's a manufacturer's built-in discount that's being added in. Once that meets $7,400 for the year, now you're taken out of that donut hole 25% coinsurance exposure, and you're put into catastrophic coverage phase. And now you go from paying 25% to 5% coinsurance. 5% coinsurance on $1,000 is $50. What Biden's Inflation Reduction Act is doing in 2024, it's eliminating this 5% coverage, catastrophic coverage phase. So come January 1st of 2024, for that entire year, once you meet the $7,400 in true out of pocket, which most of you won't come close to hitting the coverage gap, the donut hole, or the catastrophic. Most of you won't. But if you do, you're capped. And once you hit that coverage gap limit at 7,400, then Medicare, the drug plan, they're paying 100% for the rest of the year. You don't have that 5% out-of-pocket exposure. In 2025, with this regulation that was passed, you will have a $2,000 out-of-pocket cap on your drug coverage for Part D medicines in 2025. So this entire structure is shifting. You are essentially like eliminating the donut hole, the cost shifting structure. And what will be really interesting to see, especially in 2024, is how these plans build their product. Will it be, a full deductible phase to 2,000 with some of the plans, cheap premium, you are 100% responsible until $2,000 is met, and then the plan pays 100%. Or maybe there's going to be some alternative method to get to $1,000, but that is going to unfold over the next 24 months, less than that, 18 months, as this regulation takes a hold. What you can do right now, some of you might be on Medicare with a supplement drug plan or an Advantage plan right now. Right now with this regulation, you can go get your Shingrix shot, both of them for free under Medicare, whereas last year it maybe cost you $400 or $500. Also, as of 2023, all plans have insulin, not Ozempic, not Victoza, the insulin, kind of your Basaglar, your Novolog, that's all $35 copay under all Medicare plans. So there's a lot of shifting in regulation coming into this drug plan market, which is really great from a consumer side. It's closing a massive gap in drug coverage if you're on very expensive cancer medications that cost $16,000 a month in retail cost. I know that's a lot, but that donut hole is something that we are considering with every client's list of medications. So again, we're going to let you know if your 3 medications or 1 medication pushes you into that donut hole, when you'll hit it, what your cost exposure is. So there's no unforeseen copay when you go to CVS, which I've had that happen to me. It's not fun. It makes you pretty emotional when somebody says, that's a $900 medication. And no. So as you can see here, there's a lot of variables at play when it comes to Medicare. I know Joel hit on this at the start of the webinar. There is no one size approach here, and anyone pushing you towards one product or only working with one carrier, that's not really holding your hand through all of these different nuances of Medicare. Don't try to force it. Find somebody who can really hold your hand and be there each and every year. And we always recommend starting this process 6 months out from your 65th birthday. I talk to people at 63, 64 all the time just to create the timeline. And if you are able to delay Medicare because you're on group coverage, that's where I would say, hey, let's just jump on a call for 15, 20 minutes, make sure there's no mistakes being made. And then when you are nearing that retirement date, the sweet spot to start your Medicare enrollment is 3 months out from your desired retirement date. Do not wait until the last, 2-3 weeks of retirement to start Medicare paperwork. Medicare in many states and many cities, the Social Security offices who process those forms are backdated. I mean, IRMA appeals take 4 to 6 months, depending on where you reside. So again, get ahead of the curve, start planning sooner rather than later, so you don't have any headaches or, nervous Nellies at play. Again, we have a team of 20 here. Everybody's awesome. I feel very thankful and appreciative of the opportunity here, Joel. And if anybody has questions, you can shoot me an email. You can call us. We're kind of at your need and beck and call. Anytime a Medicare question comes up, don't hesitate to reach out.
Margo, this has been so helpful. Thank you so much. I think I want to go back. I was looking through the questions as you talked and tried to handle some one-off questions. It's very difficult to find questions that are universal though. And this is one of the important things that I'll reemphasize from what she just said. You know, many areas of your life, it's good to kind of say to someone else, hey, how did you handle this? In the area of Medicare, that's sometimes not helpful because maybe the way that somebody else handled Medicare isn't appropriate for your life and situation. So it's really good with this kind of a complex decision to be talking with a professional. Definitely reach out to us as your Savant advisors. Definitely, we will put you in touch with Margo if we think it makes sense. You can reach out to Margo directly as well. Her contact information is there. So we're not going to go through a general Q&A here, but what I'd like you to do is if you had a question that was not answered, please do reach out directly to your advisor at Savant or send me an email. jcundick@savantwealth.com, and that's CUNDICK. Happy to get any answers we can to you to help you with a very complex time of life. Thanks for being with us today. As a reminder, there's going to be a survey that pops up in your web browser after this webinar. Please give us some feedback. Take a moment to do that. We always want to get better at giving these seminars. Thanks, everyone, and have a wonderful day.
Thank you.